Welcome to Roadmap to Residency, Evidence-Based Applications. So in this video, we will be talking in detail about bacterial pathogenesis, the host pathogen interactions and all, and we will also solve one question regarding bacterial pathogenesis. So I'm Abhiraj, welcome to our Club 250 Matchmaker sessions. So the term infection and disease are not synonymous. Infection results when a pathogen invades and begins growing within a host, and disease results when, as a consequence of invasion and growth of a pathogen, tissue function is impaired. Our bodies have defense mechanisms to prevent infection, and should those mechanisms fail, to prevent disease after the infection occurs. So host, infection, and pathogens. So the occurrence and spread of infection. So the infection occurs when microorganisms invade sterile body tissues. Infectious disease occurs when infection is associated with clinically manifested tissue damage. Colonization means the presence of organisms on a body surface or in a lumen, but not producing disease. All persons have bacteria and some fungi on skin surfaces or in the oral cavity. When these invasion invades into the tissues, the organisms have moved into the tissue to cause the disease that is called as the invasion. And after the invasion, if there is toxin production, which may be either endotoxin or exotoxin, by the organism, then it can cause the tissue damage, which can lead to a disease. So what are the sites of entry of the pathogens? So it can be through the ingestion into the gastrointestinal tract. So the microorganisms contaminating food or water like Salmonella, Vibrio, cholera. The signs and symptoms can be abdominal pain, nausea, vomiting, and diarrhea. It can be through the inhalation into the respiratory tract. For example, the microorganisms in the air, and the signs and symptoms could be cough, chest pain, shortness of breath, coughing of blood. Generally, most of the times, whenever there is invasion, it is just at the site of the injury. At the site of injury, there is invasion, and just at the site of injury only, there is the clinical manifestation first to appear, and then it can spread to other places. But also in some cases there can be the site of injury and the site of clinical entity can be different. Ascension into urinary tract, so microorganisms that enter bladder through urethra or catheter. Signs and symptoms could be painful urination, blood in the urine, pelvic pain, or flank pain. It can be through ascension into the biliary tree, so which can cause signs and symptoms like abdominal pain and jaundice. So the sites of injury to be continued. The crossing of mucosal surfaces like microorganisms that penetrate oral, anal, genital, or conjunctival linings. Silent symptoms may include human papillomavirus, HIV, herpes simplex virus, Neisseria gonorrhea. Experience local irritation, ulceration, pain, and redness. Entrance through wound sites, which can be through direct inoculation of microorganisms, leading to the direct spread of the microorganisms. So this is the natural course of disease sequence of events in infectious disease. So first of all, there is the incubation phase, so which is the interval between the exposure and the first appearance of the sign and symptoms of the disease. That is called as the incubation period. Then there is a prodromal phase where the first disease sign and symptoms occur. Then there's called the fastidium phase where the disease is at its peak. And then there is the defervescence phase where the disease sign and symptoms begin to decline. And then there is the convalescence phase when there is the recovery period. The body is starting recovering from the infection. And then there is the defection phase where when the pathogen is killed off or brought into remission. So this is the natural course of disease sequence of events in infectious disease. Now, here we have the same chart here. The incubation period, there are no signs and symptoms. In prodromal period, there are only vague general symptoms. In case of illness period, there are more severe signs and symptoms. And then in the declining period, there are declining signs and symptoms. And then again, in the convalescence or recovery phase, there are no signs and symptoms. Also, host pathogen interaction is shown here. So through the reservoir host, it can get through the routes of entry, also through the different modes of transmission. The pathogens can enter and it can cause host susceptibility, it can cause the host infection, and again the pathogen can be spread out, and again it can transfer from one host to another host. Now this is the typical timeline of host pathogen interaction. Now let's talk about the mechanism of bacterial pathogenesis. So first event to happen is microbial adherence. So the adhesins attach to host cell receptor, often located at tips of pili. It can be component of capsules or various cell wall proteins, binding highly specific, and it exploits the host cell receptor. So the first one is tissue tropism. So tissue tropism is when the pathogens that prefer the specific tissues over others. Example, the Streptococcus mutans is abundant in dental plaque and Streptococcus salivarius, which is attached to the epithelial cells of the tongue. There can be species specificity, which means that, for example, the pathogens that can only infect certain species. Example, Neisseria gonorrhea infections are limited to humans and E. coli K88 infections are limited to pigs. There can be genetic specificity of the bacteria, which can mean that surface mutations that occur so previous antibodies do not recognize the invading pathogen. They are genetically immune to a pathogen. Example, certain pigs are not susceptible to E. coli 88 infections. Susceptibility to Plasmodium vivax infection is dependent on the presence of the Duffy antigens on the host red blood cells. If a microorganism cannot adhere to a host cell membrane, then disease will not occur. So this is the first step in bacterial pathogenesis, that is microbial adherence. Next up, we have the invasion. So invasion, it can be through the penetrating the skin. So difficult barrier to penetrate. Bacteria rely on injuries. For example, Staphylococcus aureus enters via the cut or wound, and Yersinia pestis is injected via fleas. It can be through penetrating mucous membrane, which is the entry point for most of the pathogens. It can be through direct uptake by cell. So pathogen induces the cells to engulf via endocytosis. Example, Salmonella uses type 3 secretion system to inject effector proteins, which is called as invasins, and acting molecules rearrange and they yield membrane ruffling. Or it can be through exploiting antigen sampling processes. So some pathogens use M cells to cross the intestinal barrier. For example, Shigella survives phagocytosis by macrophages, induces apoptosis, binds to base of the mucosal epithelial cells, and induces the uptake. And some may invade by alveolar macrophages, for example, Mycobacterium tuberculosis. Then occurs the colonization. The colonization is the multiplication of pathogenic organisms where toxins are produced and the normal flora are overcome. During this stage, pathogens compete with the normal flora for space and nutrients. During colonization, the host begins to show signs of septicemia, that is, blood infection where bacteria are reproducing. After that, there is evasion of host defenses. So when there is invasion, there is colonization, then the host defense system starting to act. So the bacteria have to evade the host defense to stay surviving, to stay on acting in the host. First one is hiding within a host cell. So it allows the avoidance of complement proteins, phagocytes, and antibodies. Example, Shigella direct transfer from intestinal epithelial cell to adjacent cells by causing host cell acting polymerization. Another mechanism can be by avoiding killing by complement system proteins. So the serum-resistant bacteria resist. Example, Neisseria gonorrhea hijacks the host system, binds the complement regulatory proteins to avoid the activation of membrane attack complex. Another mechanism via avoiding destruction by phagocytes, preventing encounters with phagocytes, C5a peptidase degrades the chemoattractant C5a, example Streptococcus pyogenes. It can be via membrane damaging toxins which can kill phagocytes and other cells. Streptococcus pyogenes makes streptolysin O. Other can be surviving within the phagocytes, example, escaping from phagosome, which can be prior to lysis with lysosomes, example, Listeria monocytogenes, which can produce molecules that form pores in the membrane, and Shigella species, which lies the phagosome. It can be through preventing phagosome-lysosome fusion, which avoids the destruction, example, Salmonella. Other can be surviving within the phagolysosome. So few can survive destructive environment. Example, Coxiella burnetii can withstand delays fusion, allows time to equip itself to survive. Avoiding antibodies. Example, IgA protease cleaves the IgA found in the mucous membrane. And Neisseria gonorrhea, which can show antigenic variation. After this all things, then the bacteria begins to damage the host. So the damage to the host can be via direct or indirect effect. So direct is via the toxins produced and indirect is via the immune response by the host. So damage may help the pathogen to exit and spread. Example, Vibrio cholerae induces watery diarrhea up to 20 liters per day, which can contaminate water supplies, and Bordetella pertussis triggers severe coughing, and then the pathogen is released into the air. Toxins, exotoxins, and endotoxins. So the proteins secreted by pathogens that causes damage to the host tissue. Example, botulinum toxin, tetanus toxin, and hemolyzing. This hemolyzing causes rupture of the red blood cells. Or it can be endotoxin, where the toxic substances are released when a cell is killed. Here we have one question with us. So which of the following bacterial factors is most essential for the pathogenesis of this patient's disease? A 4-year-old boy is brought to the clinic by his mother due to decreased appetite, abdominal cramps, and diarrhea over the last 3 days. The stools were initially watery but have now become bloody. Temperature is 100.4, mucous membranes are dry, and the abdomen is mildly distended and diffusely tender to palpation. Stool studies are positive for fecal leukocytes and occult blood. Stool cultures grow non-lactose fermenting, gram-negative rods, and McConkey agar. The bacteria ferment glucose without gas production, and they do not generate hydrogen sulfide when ground on triple sugar, iron agar, and cannot replicate at refrigeration. Here we have the options. On these patients, fever, abdominal cramps, and bloody diarrhea are consistent with bacterial enteritis. Stool culture results are most specific for Xylella species, which are non-lactose fermenting organisms with no hydrogen sulfide production on triple sugar iron agar. In addition, Shigella ferments glucose in contrast to Campylobacter, a cord blood that does not. Shigella is transmitted via the fecal-oral route, and once in the GIT, the bacteria is able to invade the intestinal epithelium via the macrophore M cells that overlie the pair patches. And after the cell injury, the Shigella lies its containment vacuole, multiplies within the cytoplasm, and exits the basolateral surface of the cell, where it can more easily enter the enterocytes and then spread to adjacent cells via host cell acting polymerization. Here we can see Shigella passes through M cells via transcytosis. Then there is replication inside the host macrophages, which causes intense inflammatory response. And then through actin-based motility, there is lateral spread of the microorganism Shigella. Then there is widespread enterocyte involvement, which will cause epithelial cell death. Thank you for watching.